So very good morning. So Dr. Dhananjay has talked about the recipient side. I'm talking about the other side of the knife, the donor. So managing obesity and cardiometabolic disease before and after transplant in transplant donors. So we have a case, 55 years, female, mother of the patient, BMI is 29. She is a diabetic as well, 3 years on metformin, well controlled, hypertensive, 2 years, well controlled on telmisartan. She has metabolic syndrome as well, fatty liver in common day language. LFT is normal, fibroscan has a score of 1, and her renal profile is absolutely normal. Will we consider her as a donor? Why are we talking about obese donors? Because we know that we need a lot of transplants per year, maybe 2 lakh per year transplants would be the holy grail, but we are transplanting only 20,000. And the living kidney donors, they constitute the majority yet. And now to expand the donor pool, we are taking donors with some medical conditions, and obesity is one of them. So we all know that obese donors by the international criteria is anything above a BMI of 35 they don't take. But again, as Dhananjay showed, Indian BMI, we have a lower cutoff of obesity. 25 itself is obesity cutoff. And I'm very sure, we think that we don't take obese donors, but most of the donors whom we take are practically obese if you consider 25 BMI. So 25 is our cutoff, and our donor definitely was obese 29. And waist circumference criteria also is different. We know that we have a high percentage of visceral obesity, and that also may be a thin fat Indian phenotype where BMI may be normal, still you may be viscerally obese. Now, what are the guidelines? We have multiple guidelines. What's the practical point? In KDIGO, they say 30 to 35 you can take, they relatively accept it. And most of the guidelines, they are supporting KDIGO. But what about our Indian NOTO? What does it say? Below 30, no problem. 30 to 35, relative contraindication. So foreign guidelines, above 35 is a relative contraindication. For us, 30 to 35 BMI itself is a relative contraindication. Why is this obesity? We are so bothered about obesity because of multiple mechanisms. I'm not going into the details. It has a cytokine component. It has a hormonal component, causes inflammation, oxidation, fibrosis. Fatty kidney itself leads to oxidative stress. You have so many factors in play. So these are at the end of the donor. So donor itself is at risk for oxidation, inflammation, fibrosis, CKD, cardiovascular disease long term. And the recipient outcomes we know also get affected because of donor obesity. So meta-analysis shows that obese donor has 1.76 times the risk of ESKD as compared to non-obese, hypertension 1.2 times, diabetes 1.08, and proteinuria as well. Most of the studies show if the BMI is less than 30, the risks are not high. Proteinuria post-donation is not significant. Our study showed, again, risk of living kidney donation, not much if you choose the donor ideally. But again, another study from Dr. Thukral, who is chairing the session, they said after a minimum follow of 5 years, donors with obesity showed increased morbidity and reduced renal function. And visceral obesity has worse outcomes. So in fact, sometimes we don't even look at the BMI. Visceral obesity, we completely forget about it. We should always remember YY paradox. We are viscerally obese. The Indians have a thin, fat Indian phenotype. And even if your BMI is normal, the donor might be at risk. So I have talked about donor outcomes, that you have high risk of hypertension, ESKD, diabetes. What about recipient? So overall, it's fine. But in case very obese, then you have 2.16 hazard ratio for delayed graft function. Otherwise, if you stick to obese or overweight, you may be fine. Along with obesity, you have other factors as well. Diabetes, hypertension, metabolic syndrome, and MASLD. For instance, our index case, who has everything, would you be taking such a donor? So obesity with diabetes mellitus, will you consider such a donor? You can. If type 2 diabetes, good glycemic control, duration of diabetes less than 10 years, on treatment but not on insulin, and no end organ damage at all. And here it's important that BMI should be brought down in Indian donor to less than 25. Foreign guidelines say with diabetes also, BMI less than 30 is acceptable, and lipid profile should be within normal range. So does our donor fit this criteria? No, she is a diabetic, she has obesity 29, and she needs to be brought down to ideal state. And donor and recipient outcomes are acceptable if diabetes is mild, well controlled, even in obese donor. And what do the guidelines say on that? Again, same thing, that type 1 exclude, type 2 you can take, but no end organ damage and glycemic control should be excellent. So our donor did not have any other end organ damage, but she was obese and diabetic. Now, donors with hypertension. So obese donors, 70% have hypertension, and the guidelines say you can still take blood pressure well controlled, less than 140/90, 130/80 in a diabetic, on less than 2 medications. So that may be acceptable. Again, exclude those with end organ damage, confirm the hypertension by ABPM, exclude all secondary causes of hypertension, exclude end organ damage. So if none is the case, you can go ahead with the donor nephrectomy. So our donor doesn't have any other end organ damage and has a well-controlled hypertension with a single drug. Hypertensive donor outcomes match the non-obese hypertensive donors provided you follow the strict criteria. Metabolic syndrome, another comorbidity. Again, if you have a well-controlled metabolic syndrome and cardio-kidney metabolic syndrome, the donor can be accepted, but again, more number of comorbidities, BMI cutoff 30 for foreign donors, less than 25 for Indian donors. What about that MASLD, the steatotic liver disease? It's very, very common. We have fatty liver all the time on ultrasound, which we never look at. It's important. So you can take such donors, provided LFTs are normal. Always do a fibroscan. And if no significant fibrosis, please go ahead. F0, F1 is not a contraindication. Biopsy is not required all the time. So only if you have abnormal scans, biopsy may be needed, but that's controversial. And most of the guidelines say fibroscan is the way to go. And the history also says that metabolic syndrome, post-transplant, you have conflicting reports. There are more chances of DGF in the recipient and more chances of CKD in the donor. But again, reports are conflicting. And the consensus is if you maintain the abnormalities properly, you are through. And this is supported by KDIGO as well. They say donation should proceed only if the long-term health risk is low, if it's a metabolic syndrome or MASLD in the donor. This sort of a donor with multiple comorbidities, obese, what are the guidelines for cardiovascular screening? So most of them agree, obese donor, intermediate risk, non-invasive stress testing should be done. And if it's high risk, obese with the diabetic, stress imaging, plus as per the center policy, even a coronary angiogram can be done. So our donor underwent both. Thus, for obese donors, these are the basic tests where we are looking at obesity, we are looking at the metabolic profile, and we are looking at end organ damage, including a fibroscan for the liver. When should such a donor donate? Immediate donation. Suppose our donor, would we go for immediate donation or proceed after weight loss? So it's individualized, but our donor, we have waited because we had a diabetic obese donor. So 1/3 of the studies show that they wait before proceeding to donor nephrectomy. Strategies, Dr. Dhananjay has highlighted diet and lifestyle, anti-obesity drugs are also important, and the role of bariatric surgery. Diet, intermittent fasting is the fad, healthy diet, Mediterranean diet, same works for the donor as well, same works for all of us. But what's important here is intermittent fasting has a high risk of cardiovascular outcomes. So it's better to fast in moderation. Physical activity, again, important thing is cardio plus resistance. So 2 weeks of resistance per week is important along with the remaining days of cardio. Pharmacotherapy, very important because it's available now. You have semaglutide, you have tirzepatide, very well used drugs. Injectable preparations, which one will you choose? Both are available, both cost around 15 to 20,000 bucks a month. So how will you choose? Weekly ones, injectable, weight loss is around 15%. GI side effects are common to both, contraindications are common, pancreatitis, risk of medullary carcinoma of thyroid, gallbladder disease, suicidal tendencies, but less common with tirzepatide, but both are equal. Sarcopenia is important. So weight loss, some 15% is because of muscle loss. So we should be careful about that. And protein intake should be maintained. And there are some risks about retinopathy, but not proven in the landmark trials. So we should learn to use these drugs. They are available. Semaglutide is available, Wegovy we have now, and tirzepatide, Mounjaro is available. One important thing is don't go for oral semaglutide, Ribelsus. It's not USDA approved for USFDA approved for weight loss. It's approved only for diabetic weight loss or diabetes, not for weight loss. There are other anti-obesity drugs just to complete the list, but we are not using any of them. The Orlistat, Topiramate, now no. You have semaglutide, you have tirzepatide, learn to use them. And for MASLD, resmetirom is available in the Western world, not in India. In India, we go for, again, SGLT2 inhibitors along with the GLP-1s, which was done for our patient. Dapagliflozin was started. Vitamin E supplements were given. But resmetirom is available in the Western world, but not in our country, unfortunately. Indications of bariatric surgery. So we put our donor on dapagliflozin, semaglutide, and we followed up along with diet and exercise. She was very motivated because she was donating to her son. So indications for bariatric surgery. When do we go for bariatric surgery? If in India, more than 35 BMI generally, in the Western world it's 40. Otherwise, less than this BMI, you can have a consideration for bariatric surgery, but try intensive medical therapy because drugs are available. 15 to 20% weight loss without the complications of bariatric surgery is often a chosen way. Bariatric surgery, Dhananjay has discussed, and I'm not going into details of it. Some of them are reversible, some of them are not reversible. It's a big decision, but bariatric surgery is very effective. And now we are trying to do a randomized trial as to the medical therapy vis-a-vis the bariatric surgery. So he has talked about the gastric band, sleeve gastrectomy. Sleeve gastrectomy, laparoscopic is the one which is more frequently used, significant weight loss, but problem is, think of the complications also. Oxalate stones are one of the complications, and you have to check the oxalate metabolism in such cases. He has talked about gastric bypass, mini gastric bypass, as well as biliopancreatic division with duodenal switch. So I'm not going into the details. As a nephrologist, I'm aware, I know that LSG is the commonest technique, significant weight loss, but complications are also there. Mineral deficiencies are there. Dumping syndrome is also there. So don't take it lightly. First try diet, lifestyle, and intensive pharmacotherapy. So has it been done? Yes, it has been done from our Indian center itself, Dr. Pathak. He has reported 16 donors who underwent laparoscopic sleeve gastrectomy prior to donation and had very good outcomes. BMI came down by 10, weight loss 20 kg, and this happened over a period of 165 days, and subsequently they underwent donor nephrectomy with good outcomes. So these are the problems for a transplant physician with the obese donor. Transplant surgeon also has problems. So when do we generally go for donation surgery? Generally 30% weight loss with bariatric surgery, but you should allow sufficient time after bariatric surgery, not rush into it. Look for oxalate metabolism, look for deficiencies, look for complications. Take an informed consent. So this is our chapter on informed consent and shared decision making. Everything should be laid out in the open for the surgery, for the nephrectomy as well. Remember to always, whenever you are planning surgery, going for donor nephrectomy, stop the SGLT2 3 days prior to transplant. DVT prophylaxis needs to be given. Either compression devices can be used or low molecular weight heparin dose if there is no bleeding risk. Surgical problems need to be addressed because of thick fat layers, prolonged surgery, fat around the ileum, vascular injury risk, conversion to open techniques most of the times, infection, hernias, all those things. Atelectasis. So surgeons also most of the times say no to an obese donor, but we can go ahead if we address these problems. And post-donation, also you don't have to leave the donor, you have to follow the donor, and structured follow-up is important, weekly, 3 months, 6 to 12 months, and annually thereafter, where we look at the physical attributes as well as the metabolic profile. Again, post-transplant management remains pretty much the same. The same drugs are applicable for use post-nephrectomy for the donor as well. No contraindications in the donor. Can we have a method to predict the risk upfront? We have this donor, can we? Yes. So we are all well versed with The KDPI, that we do for the donor, but look at the recipient outcome. That's for the recipient, the graft quality. Is there any score existing for the donor, for donor risk of ESKD, donor risk of diabetes, donor risk of developing hypertension? Yes, there is. You can use the risk calculator published in NEGM 2016. And our donor had a score of 0.9 after she underwent the weight loss therapy. So less than 1 is acceptable. So Indian experience about obese donors. So most of us say that we didn't find that there is not much published data because we feel that we are not doing donor nephrectomies for obese donors. But think about it. More than 25, you have an obese donor. And I think that data needs to be collected. So as of now, these were the responses. But again, I had given a very short time because I was scanning the literature for Indian data. So apart from Dr. Sharmila's paper and Dr. Vivek's paper, there is few studies on donor, obese donor, more on the obese recipient. So anyhow, I think it's high time as Indians, we should collect data for obesity defined by BMI more than 25 and visceral obesity as well. So ladies and gentlemen, I conclude by saying that it's again an individual decision. Less than 30 BMI, you are safe to go ahead, but try to optimize medically before a donor nephrectomy. Treat the donors as kings and queens. They are undergoing a surgery for somebody else's benefit, and it's our responsibility that we should take care of them. And insist on lifestyle measures, insist on drug therapy if indicated. Bariatric surgery is always an option with informed consent, ensuring the complications, but it's very effective. And post-nephrectomy, don't forget the donor. Take care of the recipient, take care of the donor as well. So thank you very much for a patient hearing.